morning, ladies and gentlemen. Welcome to this course on all about capsulotomy, avoiding and managing complications of capsulotomy in phaco and SICS. So as we know, all the steps of cataract surgery are important, but then capsulotomy, if it goes wrong, especially in phaco, you will be in great trouble to proceed with the rest of the procedure. And even in SICS also, and in the later on when you need to place an IOL in the bag and other things in the centration of the IOL, all these, good capsulotomy is very, very important. So let's see how we can manage capsulotomies and how to do it well and how to prevent complications and manage complications if they happen. So because we have multiple sessions for most of the speakers, we'll change the order a little bit. We'll have Dr. Sudeep Das talk on ideal capsulotomies for in difficult SICS situations. Over to Dr. Sudeep, please.
Thank you so much, Minu, for having me in your course. I do not have any financial disclosures in this. So the ideal rhexis in a manual SICS would be a continuous circular capsular rhexis as we do in phaco, but this is not absolutely mandatory. I mean, this is only in ideal situations, perfect situations. And there are cases in SICS where CCC may actually cause problems. If you have a rigid myotic pupil, very gross pseudoexfoliation where you're wondering whether the lens is stable or not. So when you try to remove the nucleus through a rhexis, you will actually remove the entire bag. So subluxation, black cataracts, where even I've had trouble removing a black cataract through even a pretty large rhexis. So this was a mature cataract with pseudoexfoliation, wasn't dilating. So I always shake it to see whether the lens is shaking or not. So what I'm doing is multiple sphincterotomies. In a phaco, sometimes these cause problems because they go into the phaco port. Here, that's not a problem at all. So once that is done, so now the pupil is sort of a little more dilated, a lot more dilated. And then if you see, I'm again not trying, this is the age-old envelope or the endocapsular type of capsulotomy. So I'm cutting it at Vanus. So many of us have forgotten doing all this, but it does help in situations like this. So you make 2 vertical cuts and then tear the rest of the capsule. And once that is done, there's a lot of intumescent cortex in front, so there's no hydro. And then you can sort of implant a 3-piece lens. So this is another one. You can see a little synechia there. So I'm breaking the synechia first with the with the hydrocannula and then injecting trypan blue. So here basically I am doing a rhexis behind the iris. So it's larger than the pupil. And it's an immature cataract, not a very hard cataract. And once that is done, you have to actually see that where the rhexis is. And being a soft cataract, fairly soft cataract, I can remove it through that. But make sure that your rhexis is, didn't show that part, but I always check it behind. And again, the pupil is not rigid. So without doing a sphincterotomy, I can remove the nucleus. If the pupil is rigid, it won't come out. So this is non-dilating pseudoexfoliation. So here the pupil is expected to be more rigid. So here I will put in iris hooks. And one will go posterior to the main wound. So this is not through the wound. It's sort of gone through the posterior wall of the tunnel, through the sclera. And here, once I have the rhexis, I mean the hooks, I can make a very large rhexis. And then you can sort of do a hydrodissection, dislocate the nucleus out. At this stage, it probably would have been ideal for me to have removed the hook in this patient, at least, I mean, the superior hook, which is under the wound. Sometimes that creates problems, it gets dislodged. And the other thing one can do in SICS is use 5 hooks. So like so you can see that is the superior hook is getting pulled. So ideally, you probably should have removed it and then put it back again. So here, since I have an intact, though large rhexis, I can implant a single piece PML lens into the bag. So here again, it's not as in earlier case, but this, it's very clear that, you know, the rhexis is sort of happening behind the pupil. Again, immature cataract. And in this case, you will actually see me checking the rhexis, where it is. So with the same needle, I just sort of retract the iris and check that the rhexis is all right. And this is severe pseudo-exfoliation, non-dilating, rigid pupil, very mature cataract. So if you see, I make all my incisions right at the beginning. All this marking, everything I do right at the beginning. There's no viscoelastic, nothing at all. And then I introduce viscoelastic. You can see the lens is shaking a little bit. When it touches I touch the anterior surface of the lens with the hooks, it's sort of shaking a little bit. Even that little, you know, it's a delicate touch. So here, this is the ideal situation in a SICS. To get a full dilatation, you use 5 hooks. And here, since the lens is shaking, there's absolutely no way I will do a rhexis. So sort of, there are punctures superiorly, then I'm tearing the rest of it, like you do in a rhexis. Fairly big nucleus. So trying to take this out through any rhexis would have been a problem. So capsulorhexis may be ideal in all situations in phacos. Phaco we cannot probably do unless you're very experienced, unless your rhexis is complete. But in a SICS, it may not be the ideal choice, though it's the best choice, though it's ideal. And MICS does, though I must admit that I don't do that many SICS anymore for many, many years now. I've been mostly a phacosurgeon, but but it does give you a lot of leeway, especially for younger surgeons. Thank you.
Thank you, Dr. Sudeep. But I do feel that a rhexis, if possible, in SICS would be a good idea. And can opener, if you feel that you're going to deliver the bag after a rhexis and trying to prolapse a shaky lens, then it's a can opener is always acceptable, because retaining the capsule or the bag is the first important thing, rather than trying to do a rhexis and deliver the whole bag out. But then, as he showed, the use of iris hooks to get the pupil larger and to get a large rhexis or a capsulotomy well done is a ideal thing to do even in an SICS. That would be the take home. And next we'll go ahead with Dr. Suven. Dr. Suven Bhattacharjee will talk to us on the correct technique and instrumentation of anterior capsulorhexis and can opener capsulotomy. See, can opener is not, as we saw just now, can opener is not out of fashion now. Still, we have a lot of cases which will benefit from can opener. So over to Dr. Suven, please.
Thank you, Dr. Minu, for this invitation. A wonderful course, and even on the last day, we have a reasonable crowd. Actually, in other venues, we had much higher crowd. So, I'm Suven Bhattacharjee. I'll be speaking on capsulorhexis Instrumentation and techniques, no financial interest. Now, this is the first tool that you require. I am a very much a needle person, so with the bevel up, we bend the needle tip just vertically down 90 degrees, then bend at the hub. This is a 2 bend. Now, you could do a 3rd bend, which I prefer to these days, is bend it in the middle. Now, that brings it to what is called a 3 bend system. So, you have a 2 bend system and a 3 bend system. Now, how does it offer an advantage? Is when you have a 2 bend system, there is a chance that while doing the capsular access, you will be pressing the posterior lip and your viscoelastic is going to escape and your AC is going to shallow, and that will lead to complications. So with the 3 bend system, what you do is you are not pushing on the posterior lip, you are it's actually directed towards the anterior lip, so the wound does not open up. Now, of course, the capsular access forceps, the good old Urotrata is now probably out of use. Now, mostly we have the Haldipurkar forceps, a wonderful invention, definitely. Now, I will not talk about much about canal capsulotomy because I don't have a video of a can opener, because it's been a long time. This is borrowed from Minu. I think Sudeep showed some wonderful can opener videos. Let's see a standard capsular access. So, the ideal visco OVD would be injecting a cohesive one, a dispersive one, followed by a cohesive one to flatten the dispersive onto the endothelium. And of course, the cohesive one gives you space and flattens the anterior capsule. Now, these are standard, all of you, I'm sure if you're in this hall, you are already doing capsular access. So, now this is in one go without any visco top-up. That's ideal if you can get away with it, perfectly all right, but no shame or harm in topping up viscoelastic. Now, this is where I thought there will be a little bit of a struggle. So, what I did was I wanted to top it up. So, just keeping my needle right over there, I top up the visco till the capsular access flap is flattened onto the rest of the capsule. So, now everything is under control and you can go ahead and you can do this top up as many times as you want, depending upon the size of rhexis you want, how you want to control the rhexis. There is no shame. What I'm trying to say, just stabilize your hand. If you feel that it's not stable, just hold it with 2 hands and inject that viscoelastic. Now, this is a principle which you have to understand. This is a very important take-home message. If you're injecting cohesive viscoelastic during initiation of rhexis, the purpose is to inject it in the center so that you flatten the anterior capsule. The purpose is you flatten the dome, the tear does not run downhill. Zonular forces are neutralized. Now, if you have got this part, so when you have a runaway capsular rhexis, you do not inject in the center. When you inject in the center, what you have is you're pushing the loose cortical matter from the center to the sides to result in a donut. Your runaway rhexis is going to run faster. So, what you need to do is now inject that cohesive viscoelastic at the leading part of the tear. So, that is where you flatten it and you oppose the radial zonular forces. That's when you have control, and you will see it works wonderfully. This is something which I want everyone again to know. This is going to rescue you and the capsular rhexis. So, Little's capsular rhexis. I would highly recommend that each one of you reads this original article. So, to rescue the capsular rhexis, the tear must be directed centrally and back to the desired circumferential path.
Yes.
Force applied to the capsular flap is then reversed in direction but maintained in the plane of the anterior capsule. Very important. Reversed in direction but maintained in the plane of the anterior capsule. First, unfold the capsule flap so that it lies flat against the lens cortex as it did prior to being torn. So, let's see the images from the original publication. Brian Little, a great person, has really done commendable work. So, switch to forceps if possible. Hold the flap as close as possible to the root of the tear and pull circumferentially backwards in the plane of the capsule. See that? When you then holding the flap under tension directed more centrally to initiate the tear will predictably propagate to the center of the capsule. Now, this is something which I would like to demonstrate over here. You can go back home and try this. There are 2 forces which I applied in capsular rhexis, the tear by stretching and the tear by shearing. So, when we are using a needle or a capsule forceps to tear, it's mostly shearing. It's this. Right? Now, if this is my right hand, I want to now, my capsule is running away. This is my stable part, the peripheral part of the capsule, and this is my leading the capsule. So I have done this, I have now flattened it, and I pull. It is going to come this way. You can do this again. Sorry, this is a little too much. Go back home and try it. It moves very predictably every time. So if you're doing this, now you hold this, keep this stable, see which direction it goes. It moves towards my hand. So you pull it in the plane, it moves in that direction. And that's something you can practice at home, and once you gain actually it feels a little scary. You feel that it'll go out, but it always turns back. So now let's see this. This is a situation where I actually applied the little capsulorhexis twice. Now there's a little bit of fibrosis over here. So I was struggling, and that capsulorhexis would not extend. So I used a pair of scissors to make a nick, to progress a little. So there I made a nick, and I am progressing. And that's when, after that, the first pull, and that gets a little uncontrolled. See, now there it is now already heading outwards with a fibrosis that could get messy. So I am now going to try the Little's maneuver and see what I'm doing. I'm pulling it in the direction, in the same plane. Not good enough. Go closer to the leading part. Hold that there and pull. And there it moves towards the center. Now I can control that rhexis and go ahead. Now again, there I am, again doing that. Okay, now I come back and do this capsulorhexis, and I'm almost 3/4 done, and when again I feel that it's going to run away. Hold it by the ear and pull it back, that's it. Yeah, so now that's the place where it's going to start running. There. So now I'm going to just hold that and give it that tug, sharp tug. You see how it moves. It moves wonderfully. You have full control. And I'll show you time and again. This one I'll have to little advance it probably. Yeah, so this was where I was going fine, and somewhere towards the end here. Here again I'm going to struggle a little bit. It's going to run, and this intimation cataracts can be there. It is going to now run. There. It started running, so I now give it a tug. I just change the direction, and there it is. It's very, very predictable. Now let's capsulorhexis during phaco. Now this was started off well, and now I have caused, my chopper has caused a tear at 6 o'clock, if you can see. So now I have to control this. I do not want to go ahead with my chopping with this in place. So I'm going to now hold that, and there, get a good grip, and I'm going to turn that. There you are. Now I can go ahead with my chopping and do whatever I want. So at any point when I see that my capsulorhexis is damaged, I can go ahead and rescue it. Okay, and that's where, it looks like a keyhole. It's not, that's all right, my lens is in the bag. It's perfectly centered, you see. So, now, this is little rhexis after phaco. I have still got a little bit of cortex over there, and I notice now that that place over here, there is a problem. You see there is a little problem, so I want to tear it. Yeah, I'm doing finishing. So now I try tearing it from this side, not much of help. I'm not getting purchase. I really don't. It will be a shame if I spoil this case. So now what I do, I create a nick, and now I try Little's rhexis. Create that nick, and I'm not going to use my shearing forces. I'm going to use stretch. See that? And I'm going to do that, and there. I included that radial stretch that was there. So that's about all. Thank you very much for your attention.
Next we have Dr. Gaurav Luthra speaking on when and how does anterior capsulorhexis tear, and how to proceed with surgery.
Thank you, sir. Suven, very nicely done, and I don't need to show the brand littles anymore. I mean, you gave some amazing pearls for how to keep the rhexis intact. So, I'll start with this situation. There's an ICL in situ. This patient came 7-8 years after ICL during the COVID times following vaccination with bilateral uveitis, a very severe one. and hypopionds actually. And over 3 to 6 months, as we treated the uveitis, she went on to develop bilateral intumescent cataracts, and pupil was rigid, and we had this challenge to operate this patient, and the trick was, of course, to get the ICL out first and also to stain the capsule, and it's because it's an intumescent cataract. We wanted to be sure that we don't have a complication, and also patient had astigmatism, which was corrected with the ICL, and once that goes, we wanted to correct it as well. So a tricky situation, and since I plan to stain and I don't like viscoelastic when I'm staining, I'm using infusion in my left hand and no viscoelastic at this point, trying to ease out the ICL. And once with some manipulations, I am able to get the ICL out of the sulcus and into the chamber, and then stain under the ICL to get stain on that capsule, because I will need good contrast. It's an intumescent cataract. Get the ICL out, and once the ICL is out, I'm now ready to decompress this lens. I want to make sure that it doesn't go into a flag sign, so I'm going to just decompress it a little bit, and let's start playing from here. And I want to just go in and aspirate, but then sometimes it doesn't give you that much time. It still went into Argentinian flag sign anyway. And now, of course, you have to do the best. It's a soft cataract. It's a young patient. She's about 35. And now you can convert this into a rhexis. And of course, then you have to fashion a rhexis out of that. There forms one side and the other side, and then you can complete the surgery. But how can you preempt this? So of late now, when I am dealing with such situation, I was lucky I could get away with a toric IOL here, because the axis of implantation was such that it would remain away from the area of the broken rhexis. But for the second eye of this patient, which also had almost a flat vault with an intumescent cataract, not as intumescent as this one, but still fairly intumescent, we went with a femtosecond laser assisted surgery. And you can see that the femtosecond laser can detect the ICL as the anterior capsule of the lens. So here you'll see that that ICL is sitting in situ, and then the landmarks are all gone haywire. So you have to set them up. Here it's detecting the iris actually in this plane rather than that plane. So you set that right. It also detects the pupil as the edge of the ICL. So you have to reset all those things. So not important messaging here regarding that, but frankly, you can actually then do a very good rhexis under the ICL, and that will ensure that you still get a good rhexis. And so anyway, we've managed to do this, and let's not waste time on this, but that's just one way. Now, Suen has already shown some of these recovering of the running out rhexis, so I'll bypass these, the brand littles also, and go to something which happens sometimes. Now here I'm going again, it's an intumescent cataract. I'm trying to decompress. I'm not holding the globe with the left hand. I don't like using forceps on the conjunctiva, but you need to stabilize the globe, and you'll see what happens if you don't stabilize it. And I thought my needle was sharp enough. I like to go in from a closed paracentesis chamber with full viscoelastic inside to decompress the lens and just see what happens. There will be a sudden entry. There goes, and it goes and punctures and makes a radial incision on the capsule. So now I'm having a radial incision there over there, and I have to bring it back. So there is this long, incision from the 26 gauge needle that I was using. So I anyway still go in and make a fresh entry. It's an intumescent cataract, and make a small initiator rhexis kind of a tear, aspirate some of the cortex and decompress the lens, and then I'm going to go with this forceps and microrhexis forceps and try to go around that radial tear if I can. So, going from two sides and going beyond that and kind of coming from two sides, and if you have a small nick in the capsule can be a good thing. So this is how you can deal with it, and some brand littles kind of maneuvers here to bring it back. Fill in viscoelastic when you have to. And of course, make sure that you have removed the decompressed the lens. So I was lucky I got away with this, and I was able to complete this surgery. This happened to me in live surgery. You can see on top left, I was starting off this case. I think this was in Amritsar. And as I started this surgery, you'll have to excuse me because I just couldn't find the edited version, so I've just brought in the raw video for a moment. Now, I went in with an MVR. Now, I like to use an angled MVR, and I forgot to carry my own knives there. And angled MVR, that too has to be very short part. The bent part should be really, really short. And it should be angled at the right, 30 degrees or whatever, so that it doesn't point towards the lens. And I got a blade which was not very sharp. It was straight. It was a straight MVR. And I hate straight MVRs because, they are prone to, cause problems if the patient, there's a strong bells or something. So just see what happens. I go in, and because it's not sharp, it just goes and punctures it. Now I have a very peripheral puncture. It's going all the way till there. So if I have to retrieve this excess, and I have like 5 top surgeons standing all around me trying to give me advice how to go about this surgery. And each one of them has different advice. So I tried to do something about it, and I went ahead with my other incisions, thought for a while what I should do, tried to see if I can hold on to it and bring it in, but it wasn't. It was almost radial. So there I'm trying to do something about it, but it doesn't go the way I like it. So then I start initiating a rhexis from elsewhere. When nothing else works, I thought that I'll go around it, but eventually what we did was we let that small break be alone. We made a rhexis as usual and just ignored that small puncture in the periphery. And we were able to, because I was not using any forces in that area, at the end of surgery I was able to actually do everything right. I'm sorry, it's not, contrast is somehow not good because, but at the end, I had an intact rhexis. I had a puncture there. Frankly, it did not extend, and I was lucky I got away with it. So yeah. Now again, he's already shown you a few things. I'll just show you. In this patient, I had a rhexis which was, I was somehow getting a small pupil and I was managing it. And here it started running out over here. And I had no space. I was trying to use the micro rhexis forceps, but it wasn't allowing me. And I then used an iris hook because I tried to use a Y-tip manipulator to move the pupil to the side, but this was just under the main port, so I had no access, and I was using the side port for my micro rhexis forceps at that point. So sometimes if you get stuck, you can just use something to retract the pupil, and it'll just help you complete your rhexis and get away with it. I'll bypass this and come to a broken rhexis kind of a situation. Now this patient had a hard brown cataract with a very fibrotic capsule, something like what Suven was showing in that Morgagnian cataract. You can see these fibrotic bands over here. And I was trying to see if I can make a rhexis over there. And since I could not proceed over there, I started from the other side. Now, when I reach this point, it again is difficult because it's going to break there or it'll run away or something. So I then initiate a small second nick over there and then come around and bring it in from the other side and manage to then complete it somehow. And this is a hard brown cataract, so I need to have a slightly bigger rhexis. You can see that small fibrotic band there. Yeah, and I've completed it, but this leaves a suspect area. Now I proceed with surgery, but at this point, everything is going great for this time, but there's a lot of lateral separation required. My rhexis is not big enough. It should have been even another millimeter or two bigger in size. So you'll just notice that as I'm going through my cracks, and there the rhexis breaks from that point where I had that small fibrotic thing. So just keep watching. Just watch that area. As I do lateral separation, my rhexis will just give way somewhere here. And this lateral separation, and it just goes out. So these are weak points. So what I'm trying to convey is, sometimes your rhexis will have weak points. Either you'll have a small notch on the rhexis, or you'll have completed the rhexis from one way or the other, or you'll have some fibrotic band. And if you do lateral separation or maneuvers in that area, you have to keep away from those areas and not let forces transmit to that place. Otherwise, the rhexis will usually give way from those areas, and then you'll be in a situation. And sometimes if you are having a small rhexis, it's a good idea to give a small nick and enlarge it anyway, because trying to proceed with a very hard cataract with a slightly smallish rhexis, you will eventually put forces on the rhexis. So I realized that there was a rhexis break, and then I went a slow motion phaco, and very gradual, then small pieces, and then getting each one out. It's laborious. Pupil starts coming down, but eventually you will get it. And as long as the flap motility sign is with you, which means that the flap is motile and is moving freely and it's pointing upwards and out, you're lucky and you'll be fine. But yes, if you're not conversant with good phaco, you should convert at this point. If you are very comfortable with doing phaco in very challenging situations like these, then you can still stay on, but otherwise you can convert. I think I have a minute left or I'm done. I'll just show one last case, okay. So this was a patient referred to me, somebody had started a surgery and had a runaway rhexis, was a learner surgeon and didn't want to pursue it further. So I had referred this patient to me and there was a run out in this area. I will go in and try to check if I can retrieve it, because if there is still possibility of bringing it back, I would like to do that. But I realize that it's gone too far, so I will initiate. Now there are two ways to do it. Scissors would be a great way. Sometimes I just do this and I'll still get a flap, but a scissors is more definitive. I would recommend anybody wanting to do this should use a scissors. See, I wasn't able to do it and then I'm just coming inside, and maybe this is not the best direction in which to give that cut, because it should be slightly parallel to the area where you're planning to do this, not radial. And then you try to fashion a bigger rhexis than you would normally do, because now you need more room. It's a runaway rhexis, and maybe it has gone to the posterior capsule as well. We won't know about it till we start surgery, and that's where the flap motility sign will come in handy. So complete that over there. Try to make as much of a rhexis as possible and leave that weak area. Don't do any manipulations over there, and you can see that the flap motility sign is still, as I said, it's with us. The flaps are, twirled up, and the moment it goes to the posterior capsule, they'll just, turn inwards and go down. So there you can complete the surgery. I think I'll stop here because there are lots of good talks to come, and Haripriya ma'am is already here, and so thank you so much for giving me this opportunity. I'll be happy to answer any questions, and then I have to.
Thank you so much, Gaurav. That was very challenging, but also at the same time very practical. And the Little's maneuver is something that I think all of us should master. The next talk is by Dr. Haripriya Arvind, and she'll be talking on techniques of pediatric capsular rhexis, enlarging a rhexis, retrieving a running out rhexis. We think pediatric cataracts are like any other cataract. We are mistaken. Go ahead.
Thank you, Dr. Sudeep and Dr. Minu, for this opportunity. So the lens capsule, as we know, is the thickest at the anterior and posterior pre-equatorial area. It's about 20 microns, and it's thinnest in the PC central pole. It's about 2 to 4 microns. Now, the anterior capsule, it generally increases with age. So in a newborn child, it's about 4 millimeters. It becomes about 20 to 25 millimeters by the time someone is in their adulthood. So what happens is, in a child, you have to remember that being a very thin capsule, this also tends to be very elastic. So I'll be sharing the part about how do you manage an intumescent cataract rhexis. So this is when things go well. In intumescent lens, as you know, sometimes you're not sure, but you find that the intralenticular pressure is not much, so you're able to do a complete rhexis comfortably. But not always you will have this advantage. So one has to remember to always stain the capsule, use a good cohesive viscoelastic, and I'll be showing my technique of how I would deal with this intumescent lenses, either by doing a double rhexis or by doing a spiral technique. So once you do have the small nick, the primary nick has to be very small according to me. This way the initial rhexis would also be small, and this reduces the chance of extension of the capsular rhexis when you have this raised intralenticular pressure. So use a high molecular weight viscoelastic, and I would like to go in through the main wound, and then after the rhexis is complete, this is not adequate for phaco and lens placement. So I'd like to do a complete hydrodissection right after the rhexis. Now because we have the capsule stain and there is contrast, one does not need to worry about the visibility. So after this, you can go ahead and make a double rhexis. Now your interlenticular pressure is reduced because the hydro is complete. And then you make a small nick with the vanas and then go ahead and enlarge your rhexis. And most of these capsules are friable, being an older age, so they don't tend to run away unless your interlenticular pressure is still high. So once that hydro is done, then this should be fine because you also have a good visibility and contrast. In another situation, one may also consider doing a small rhexis but enlarging it towards the end, what we call as a spiraling technique. So in all these intumescent lenses, one uses a rhexis forceps. So please invest on a good Utrata. So this one is from Epsilon and is a Haldipurkar forceps, and this works very well through a 2.2 as well. So you towards the end, because you still have a well-formed chamber, you can go ahead and use the same flap and make it a little larger. So you don't have to close it. If the pressure is high, you can make a small rexus and then enlarge it later. Otherwise, towards the end, continue with the same flap and make it larger rexus. In spite of some of the best efforts, like this is a patient with silicone oils, a lot of vitreous upthrust. So the rexus is being initiated through the side port. So you can see that the anterior lens surface, in spite of using a good viscoelastic and initiating it from the side port, there's a lot of pressure in the eye. And you do have a situation where, in spite of our best efforts, the capsule may go out to the periphery. So the Argentinian flag sign can happen. So one can handle these cases by just, you obviously don't have the chance of doing a rexus now. It's not a continuous tear, but you can create more space and make a nick in the anterior capsule flap and then just close it. So this way you have at least a circular space in the center. Now having the rexus having done at 2 points, it still is okay to continue with phaco, but please remember we don't have an intact rexus. One can either go in through the main incision or go in through a paracentesis and make these micro nicks with this micro forceps and then make a larger opening in the anterior capsule and then continue with phacoemulsification. Now, in case the rexus tends to run out, so the previous case we saw there was nothing one can do. It just splits in the center and it goes out. This is what you see in intumescent cataracts. But in other patients, sometimes things seem to go well, especially if they're younger, like patients who are at third or fourth decade. We would think their capsule is the same thickness and we would go with a routine amount of tensile force. But what you will see that the rexus may go out. At this point, the Little's technique is very useful. With the Little's technique, one will have to grasp at the edge. In case you find the rexus is going out, one will have to grasp with your rexus forceps towards the edge of the flap, hold it, and then pull it backward. What the technique described is called centripetal force, which is more towards the center. But I would go a little further and say try to pull it backward, and this will change the direction. So you will see that if you do this, almost always you will be able to complete your rexus, unless if your nucleus is already been removed, you have the empty capsular bag, or you have a hypermature lens and you don't have that nucleus in the bag, there you'll find it's difficult. You may have a toned rexus. Otherwise, if the nucleus is still there, Little's technique works very well in most cases if you're able to hold on to the edge of the flap before it extends. Now, this is again an intumescent cataract, an SICS incision. The primary nick is made. Again, it's a large flap. It's tending to go out. At this point, one has to resort to using a forceps, go towards the edge, hold the edge of the flap, and you can see the movement. It's pulling backward, not forward. So normally the rexus you go forward, but just look at the tip of the forceps. You don't go forward, but go backward. I'll just show that clip once more in a little slower motion. So just watch the movement of the forceps. So by pulling it backward or centripetal forces, you'll find you can change the direction of the advancing edge of the rexus. So that is the movement one has to take when you find that the rexus margin is extending to the periphery. This way you can retrieve most of the extending capsular rexus, unless it is something like an Argentinian flag sign where it's already gone out all the way. In a pediatric rexus, again, staining is very important because most of these cataracts are either lamellar, in which case again you're not able to see the rexus edge, and they are total cataracts, so it's very important. And a cohesive viscoelastic, even more important in a child because they also have low steral rigidity and the eye tends to collapse. So you'll have to have a good viscoelastic and you tend to have a lot of vitreous upthrust. So investing in a good viscoelastic is very important when taking care of a pediatric capsular rexus. So in a child, we always go superior and always go sterile corneal because of the low steral rigidity. Never go clear corneal in a child. Again, make sure that while the anesthetist is, has intubated, you position the child such that you have a comfortable approach, because sometimes they would have the chin too low and you may not be having good visibility sitting on the superior side. It has to go superior in a child. And always use forceps and have a control. You can't make it too small because you'll have to make a posterior capsular rexus in all children, at least below the age of 6 years, to avoid the need for a YAG. So make it adequate sized, about 5.5 millimeters, 5 to 5.5 millimeters is the right size. The posterior capsular rexus will be important. This is in an adult patient who has a PCO, but in children this is 100% mandatory. The capsule thickness is almost the same, but remember in a child the vitreous upthrust is much more. So you will have to use a good viscoelastic and then do the posterior capsular rexus. So the posterior rexus is pretty straightforward to do. Only thing is you will have to ensure it doesn't go out too large. Now this is a slightly larger posterior rexus, but it has to be smaller than your anterior rexus. And while placing the IOL, especially a foldable lens, direct the leading optic haptic junction into the bag between the anterior and posterior capsule. Because instead of dialing, you just want to be able to tuck these haptics below the optic. This way the IOL will be in the bag and well centered. So in intumescent and pediatric rexus, both of these are challenging, but use of a good viscoelastic, investing in a good rexus forceps and some modification of technique can go a long way in getting a consistent rexus. Thank you.
Thank you, Dr. Haripriya, for joining in from your course and delivering this talk. So I have finished mine there and yours, so they're expecting you there. This retrieval maneuver, one point which I have noticed it, I have noticed it, where when you are trying to retrieve it, if you are going to go slow, it tends to go further into the periphery. So if you catch just next to the point of tear, and you're decided that you're going to pull inwards, pull briskly. Don't be scared that it will go to the periphery. Slower you are, the more it will go to the periphery. And the placement of high molecular weight viscoelastic should be outside this, not in the center. Should be in the mid-periphery or beyond that area of tear, which will flatten out that area. So these are two things which I have found.
Actually, whether you pull it slowly or fast, it's going to go in the direction that you want it. The advantage is when you pull it fast, you don't give your time for yourself to get scared. Because initially when it starts moving, you're not very sure which direction it's going to go. So if you pause, then you lose control. So if you go fast, you just don't think about it. You just pull it. And it is going to go in that direction.
Okay, so now we'll move on to Dr. Amit Porwal. He'll talk to us on dealing with anterior capsule of mature cataracts, hard brown cataracts, and hypermature cataracts.
Thank you, Dr. Minu. And for the audience, most of the tips will be the same, most of the procedures will be the same for the rexus, what everybody's been talking about. The cataracts also are same. They'll be hard, mature, intumescent, soft. But every surgeon has one tip, which if you can pick it up and take back, it will be very advantageous to you all. So no financial disclosures. So we all know these mature intumescent, hard brown and hypermature cataracts, most of them are swollen, congested. There's hydration of the lens matter. There's increase in intraanterior pressure. These lenses are very bulky. These cataracts are bulky. They're usually associated with mid-dilated pupil and pseudo-exfoliation. So what are the problems which we face during performing capsular rexus? The anterior capsule is, when we look at the anterior capsule, there's difficult visualization. They're calcified, they're stretched. There can be pseudo-exfoliation material, there will be loose zonules. There can be a peripheral split, which after the first puncture leading to the Argentine flag sign. So it's already been discussed by my previous speaker. What is described in the literature is mini rexus, snail pattern rexus was very nicely demonstrated. Sometimes when you're doing the rexus, your rexus gets extended, and what Dr. Minu was telling, snap it, pull it towards the center, and you will end up in getting a heart-shaped rexus. And in this intumescent cataract, we can also do a puncture rexus. But what I'm going to recommend is, and what I do, and what I've published. So this is a mature intumescent. This is a mature intumescent cataract. Staining of the capsule is very, very important. Why staining is important? Because these capsules are elastic. The moment trypan blue dye touches this capsule becomes rigid a bit. So when you have a rigid capsule, you have a better control. Now you see, I am piercing the center of the anterior capsule with a 24 gauge needle, which is mounted on a 2cc syringe. You have to be gentle, steady. Only the bevel of the needle should be pierced inside. You should not have any tremors, and you try to aspirate. The moment I aspirated, you saw the bulge, the convex became concave. Now put a cohesive viscoelastic. Again, you should not overfill the anterior chamber. It should be just adequately filled. Start with a small rexus. whenever you do this intumescent cataracts, always start with the small rexes and then you can refashion it. You can, now I'm doing this a snail pattern. First started with the small rexes, then I thought I have a better control, I can do a snail pattern rexes. So you have to decide on table which technique you are going to adopt it. Always make sure that the flap is flat. Even if you have a decentered rexes, in this type of cataracts, don't bother. You know that what will happen. You take out the cataract, inject the IOL, now you saw the rexes was decentered. So what I'm going to do is, with the micro one, I gave a tangential cut, and then I'm refashioning the rexes. This you can do with the help of a cohesive visco, but now what I found out was, with the hydration cannula in hydration port in one side, and with the Caesar on the other side, you get a better control. See, once again I'm showing another video. I pierced inside, I'm aspirating. You saw the concavity which has appeared? So this is important. So the central concavity is there, and in this concavity, what happens is there's a mid-periphery bump. So when you start with your rexes, now you should know how the tear has extended in the center. First tear, what you are going to do. So you have to make sure that you do practice your rexes with both right hand, left hand. In your cataract set, you should have a rexes forceps, a capsulotomy needle, as well as a 25 gauge micro rexes and micro vanas. So if you have not started eating with your left hand, you start eating with your left hand, start using your left hand, because you don't know which hand you are going to use. So in this case, my initial rexes only was large enough, so I didn't have to refashion it. Another technique to deal with them is an anti-react capsulotomy. Give one shot of 1.2 millijoule of energy into the center of the anterior capsule. You saw that? One shot and the whole liquefied vortex falls down like a Niagara Falls. Everything comes down, then you shift the patient to the OT, and then the convexity is lost, the interventricular pressure is reduced, and you can perform. You can see now, one shot I am giving, see. The whole liquefied vortex comes inside. Whenever you give one shot in the center, they are never going to extend it. This is the way the capsule will look after the AIOC capsulotomy when you are staining the anterior capsule intraoperatively. We have documented this. The AC depth does increase in these intumescent cataracts. We have published this in the Asia Pacific Journal of Ophthalmology. And we also did another comparison of different decompression technique and different rexes pattern. And we won the best physical poster in the AIC DreamCon. Coming to hypermature cataracts. How you are going to deal with these hypermature cataracts? These hypermature cataracts, most of the time you will encounter some calcified spots on the anterior capsule here and there. They will be Morgagian type. So when you are doing the rexes also, the nucleus will move here and there. You don't have enough rigidity. So this rexes marker you saw, I just put a rexes marker on the cornea, which gives me a rough guide that my rexes is going to be 5 millimeter. So you see, when I'm doing, you can see on the anterior capsular flap, some calcified spots are there. So when you're doing the rexes, you make sure that you don't go over the calcified spots. If you go over the calcified spots, then you are going to extend the rexes. Try to include or exclude the calcified spots. The first puncture, it's a Morgagian cataract. So everything has come out, and now you see there is a nucleus, there is a bag, but there's no support anywhere else. So now when you do rexes in this type of cataract, what happens is the support of the nucleus below the capsular flap is not there. So what you can do is you can put the cohesive visco into the bag also, because that also will give you some resistance. See what I'm doing? I'm putting it inside the bag also, because that will give some resistance also, and I'm doing the rexes. Sometimes when there is no support, you can just move the nucleus towards the part where you're going to do the rexes. So the nucleus will act as a support over there. So these are the small tricks what you're going to do. See, the rexes marker is very, very important. This, another thing, I'm aspirating it, but you saw this was it looked like intumescent, but not much of fibers, material was aspirated. It was still convex only. So then start with the mini rexes. These 25 gauge micro rexes, micro vanas are very, very important. You should have them in your cataract set. They are very delicate, you have to maintain them, but they are of great help. So you can do a small rexes or you can do a snail pattern rexes, and whenever you feel that the visco is getting escaped, always put a cohesive. If your bag is getting collapsed, make sure that you inject the visco into the bag. This was a small rexes, no problem. I implanted the IOL. Always give a tangential nick and then refashion the rexes. If you are well versed with this, you start doing with the irrigation port. Why with the irrigation port is good is AC is maintained and the flap goes on moving around. So you get a better hold with the micro rexes. This is a hypermature cataract, the Morgagian cataract. The whole nucleus is sunk to one side. So I am giving the first puncture over the nuclear base only now, where the nucleus is there. Now this nucleus has to act like a guide or the base of the support above which I am going to extend my rexes. So now you see, if the nucleus support was not there, then the rexes would have gone in a different direction. I have filled the bag with the cohesive visco because I want the bag to be inflated. And this is the way the rhexis is managed in these patients. When you come at hard drawn, again the problems are the same. Visibility is there. So, and the pupils are mostly mid-dilated. So what I call is a judgmental rhexis or AMR, that is Andajma rhexis or a blind rhexis. So you see these are the brown cataract. It is totally brown, you don't have any visibility. You use red glow, any glow, nothing is visible. It is only black thing what is visible to you. So staining of the capsule is very, very important. I've been always stressing this, and staining should be done properly. Always take a tuberculin syringe, take about 0.2 to 0.3 ml of the dye and air in that, and then first inject the air and then the dye. You see how hard this cataract is. Because of the good staining, this capsule is there, stained capsule is there, and we can visualize that this capsule is stained and we can visualize it. If this capsule was not stained, visibility would have been very, very difficult. See, this is in an SICS case. What happens in SICS is you can have a large rhexis. You need a large rhexis in the SICS because if you get stuck anywhere, because the large rhexis, you can prolapse the nucleus into the anterior chamber. And you saw in between, we know that the rhexis is going to extend, we can rip it off or pull it towards the center. So the important pearl for managing this cataract, especially the mature intumescent cataract, is intraintegral decompression. You can do an anti-ag laser capsulotomy or a slow and guarded decompression of the raised intraintegral pressure. For hypermature cataract, fill the bag with cohesive so that the bag is inflated. Use CTR, needle, forceps and nucleus as the support while doing the rhexis. And for hard-drawn cataracts, improve the visibility with trypan blue, or you can use a extra torchlight illumination from the tangentially from the limbus, and you can see that. And you should know how to tackle the pseudo exfoliation and the small pupil, and I would advise to do a large rhexis. Thank you.
Very extensive on mature, hypermature and intumescent cataracts. It is difficult to do, but then if you have the right instrumentation and the right viscoelastics, it is possible in almost all the cases. So I'll move on to the next topic on femto and zepto capsulotomies. Okay, I have no financial interest in this. So femtosecond laser capsulotomy. I'm just trying to show you the no financial interest, but this is the Alcon platform. Now I use the Zemer platform, but then this is the view which you will have. There is a PI, patient interface, which you use to applanate on the eye of the patient, and this is a contact method. And once you applanate, you will get these indicators. You can adjust the size of the capsulotomy. You can adjust the types of cuts which you make. It can be cylindrical, it can be horizontal cuts, multiple cuts, you can number them, and adjust the location of the incisions also. Better be clear corneal because it doesn't go through hazy cornea, or large arcus it doesn't cut, and towards the limbal area also it doesn't cut well, so be on the clear cornea. And this location, according to the pupil size, you can adjust the location of your rhexis, but once it has captured the limbus margin, it centers by itself. And if the pupil is decentered, let the rhexis be there. But if the pupil is too small and it is going to cut through the iris, then we have to manually change the location of the rhexis margin. And once that is finished, we will get the OCT of the anterior capsule. Now this is a good dock. The space between the edge of the dock and the sclera which is seen is uniform, and that's why you see a straight line here, which is the capsule is flat and stained, and this is the area where you get the laser into the nucleus, and you leave around 500-600 microns below as a space where you don't do laser between the nucleus and the capsule so that you don't hit the capsule. And here also we see the incision, we can place it according to the area which is clear, and once that is done, the firing starts. The capsulotomy happens first, then the nucleotomy. It can be nucleus softening into small grids of nucleus, you can make it, or any pattern of your choice. And once that is done, it is released. And this is a look on the table. Mostly nowadays, after everything is titrated well, the capsule is freely floating. But to make sure that it is complete, I do it in a circular fashion so that some bridges or some connections in between, if it is there, that is also taken out cleanly. And this is the look after this one. It is so well centered and so circular. and the positioning of the IOL will be the most perfect ideal thing which you can expect. And when we face hypermature cataracts, main problem is that the patients cannot focus on the light so very well, and so the placement of the PI will be slightly difficult. We may have to block the patient. And see here, this is not a very centered dock. See, the sclera here is seen more. But still we can center the capsulotomy manually. But the problem here is that there is free loose cortex and even milky cortex inside. So here when the capsulotomy happens, if some area finishes off first, the fluid starts leaking from there, and once the fluid starts leaking, two things happen. One is the level of the capsule goes down, and also the milky fluid comes into the anterior chamber and blocks the laser. And in these kind of white cataracts, the laser doesn't go through and the nucleotomy does not happen, and you mostly will end up with a partial capsulotomy here with some attached laser. See, this is the way you can have the milky cortex coming out into the anterior chamber, and then the laser passing through will be more difficult and you'll get incomplete cuts. So whenever I do a mature cataract, I always stain over the capsule so that I can identify where there are connections. If there are connections, I would just not pull. Sometimes if you pull, you may leave tags there. So I will just include that area also and take a see. Now you can see one small tag which is there, but later on that also can be managed, and you'll get almost a circular rhexis. But in this case, if you can notice, this is the only attachment. All the rest is free and it is floating. So what I do is, just like a rhexis, include this area also within the rhexis. So I'm going outside this because there will be some areas where the laser has fired and there will be weak areas there. So that will tend to extend during your phaco. So this will become little irregular here, but still that area, if it is included in your manual tear, then that weak area is gone. The major advantage of femto in this kind of subluxation is that we can manually place the rhexis margin centered to the lens. So the lens, if it is moved to one side, if the rhexis is centered to the lens, you will have adequate. So here you can see the positioning. Here the lens is subluxated here, and so you can move it away from the area of subluxation. You can have more anterior capsule free here, so that you can apply the capsule hooks and the easy placement of the capsular tension ring and all those. In small pupil, it's not worth it doing if it is less than 3 millimeters. But if it is 4 millimeters, still you can do a capsulotomy. This is a 3.6 millimeter. That is in some machines, that is the minimum you can do. And you can continue with phaco if it is a soft cataract, and the pupil becomes further small. It is more difficult actually with a small rhexis to go on. So ideally, I would put iris retractor hooks and enlarge the rhexis, which we have done, and then proceed. Here I have done it completely with the 3.6 rhexis, and the IOL, accidentally it is opening within that rhexis margin, which is not an ideal thing to do, but still that rhexis margin holds. It doesn't break. A 3.6 and a 6 millimeter goes in through that. So it's not as weak as we think it is. It is quite sturdy. And then I extend it. But now we have this Zimmer machine which can be kept in our own cataract OT. Need not go to a separate room, and it can be done sterile. The handpiece is sterile and the whole unit is sterile, and we can even place 2 paracenteses and put a BHEX ring of Dr. Suen, and then wash off all the visco, and then form the chamber, and then do this applanation gently, and you can finish off with the ring on. So, but it is a little big hassle. But previously it was difficult because the patient had to be shifted to a different room, and the sterility factor after opening the eye you had to shift. Now you can have sterile drape on and do the 2 paracenteses and go through the paracenteses and place the ring, and then bring the machine, the the handpiece can be moved, and bring the razor head onto the globe and then finish it off and take it out. If you have visco inside, you may need to increase the energy and titrate it accordingly, but you don't have to have visco. Because it is a 1 millimeter opening, you can always hydrate it and close it off tight, and then do the regular rhexis. This is for information, because I don't do this. I don't do this. It is not worth the trouble. But sometimes, see, these kind of when the laser falls on this one, there will be adjacent areas where there are some laser spots which are there. So some weak areas may be there. When this lens goes in with a jerk, in this case, if you notice, it was a complete rexus here. So now, once the lens goes inside, you can notice because of the pressure in the bag, the anterior capsule tore. The lens went into the bag, but the anterior capsule tore here. And so, remember, there may be laser spots which are adjacent to the cut area, which have been fired to the edges of the capsulotomy margin, and they may be weaker and be slightly gentle with your femtorexis. And the cost factor is definitely there, and it will be almost double the cost of your premium IOL patient's cataract surgery. So that is coming down now, but then still it is on a high end. So please choose wisely whether you need to have this to do a rexis, but it is for a completion's sake in a tertiary institute. If patients ask if you don't have laser assisted surgery, then you should be able to offer this. That's why we have it. So moving on to Zepto, it is precision pulse capsulotomy. It is more electrical, and this is a handpiece which is connected to a machine. This is a disposable handpiece. It has a silicone cup with a nitinol ring there, metallic. Electricity is passed through this, and when you push this central thing, it bends. And this goes into a 2.8 millimeter incision, and it can be placed centrally on the capsule. And then when you press, there is and this is released. The central push piston is released, and this opens out. And that can be placed on the center. And when we apply vacuum, this silicone ring holds onto the capsule. You can just see the edges of the capsule here. I'm trying to center it. And after that, see the edges, there will be some suction on the capsule. And you'll see some folds on the capsule which are forming because of the suction here. See the lines? So, and then the energy is delivered, and it is so quick, and it is one shot, it makes a complete rexus with the electrical pulses, low energy, fast electrical DC current which is passed through, and you get a complete rexus here. And it is simple, easy, and it is cheaper than your femto. But I don't know, somehow it has lost its fancy. Nobody uses it nowadays. But here also I had a problem, because see, I just did a hydro dissection and a regular case, and I decompressed the bag. And just after that, look at this area. This area, the capsule is open. And I will show you more. Look at these two edges of the capsule here. It has opened up. Just, I did a hydro and just did decompression of the bag, and the capsule tore off. So all these have weaker areas, and our manual capsulorhexis is superior in strength to most of these additional instruments. So our next speaker, Dr. Naren, had to leave because of an emergency. So I am going to deal with his topic also of weak zonules, capsulotomy in weak zonules, and capsule stabilizing. See, these are no zonules. So here you may get vitreous in the anterior chamber before yourself. So before doing a capsulotomy, we have to clear the vitreous from the anterior chamber. Once the vitreous is cleared, this area is plugged with dispersive viscoelastic. So when you put dispersive viscoelastic, that area gets plugged, and then you can put your regular visco on top of your anterior capsule and continue with your rexus. So here, many times we realize that the subluxation is much more when it dilates fully on the table. So it may not dilate completely, you may not realize it on the slit lamp, but see the area of subluxation there. So doing a capsule rexus is difficult. I will come to that in the next case. But capsule stabilizing devices can be applied well only if you have a rexus. So that is very, very crucial. This is a capsule hook which goes up to the equator. So this is long, and the tip is blunted. There are other ones also which is made by MST, which is broader. It goes into the equator. So that supports the equator of the bag, and you can delay the placement of the capsule tension ring. Again, the placement of a capsule tension ring, the presence of a rexus is mandatory. So once the rexus goes inside, I use this forceps again. As Dr. Amit was telling, use of these micro rexus forceps is very, very important and crucial. Please have it in your armamentarium. And after placing the CTR, I release the hooks and then place the lens in the sulcus and then capture it into the rexus margin if possible. And this is another case which is a subtle, very subtle subluxation, anterior subluxation. You don't see the margins, but the chamber is very shallow, and there is a loose zonules all around. So here again, while starting, you will see the movement of the lens. This will indicate that the zonules are very loose all around. So sometimes you may not be able to complete it because it is so convex. You may have to approach the capsule from different locations. And if it is too loose, you will see while puncturing itself it is difficult. You will see folds radiating from the puncture. So that again shows the zonules are weak in the periphery. So use very sharp instruments and microrhexis forceps if you need to, and complete your rhexis. And without rhexis, it is very, very difficult to place these kind of stabilizing devices. Now the lens goes into the sulcus, and because there is no PC rent, the bag will have a lot of viscoelastic, and I try to drain the bag as much as possible. And after that, with irrigation itself, I tap one edge of the optic under the rhexis and this edge of the optic also under the rhexis margin. So the CTR is inside and the lens is in the sulcus, and the optic gets captured within the rhexis margin, and that makes the whole complex very stable, and the rhexis phimosis is also reduced to a certain extent. So this is a very difficult black cataract with a pseudo exfoliation with a lot of zonular weakness. See the movement of the lens. When you touch itself, it keeps moving. So that is when you struggle to even initiate. So using a very sharp instrument, we can slightly make a small nick and initiate a rhexis. But trying to extend it, it is very difficult to do it with one hand. So there is one technique which, because there is less counter traction, that is a problem. The zonules are not pulling it towards one side and there is no counter traction. So I use two of these forceps. One to hold the rhexis margin in the opposite direction, the other one to pull. So this gives counter traction. So then you can proceed with your rhexis without creating more zonular dialysis or creating more traction on the already weak zonules. And once I complete, most of the times we'll end up with a very small rhexis because it will not tend to go to the periphery. If so, you can always extend. It takes a long time, but then take your own time, relax, give block, and then do it very gently, because without that it is very difficult to continue. And here I can place all my hooks on the iris, on the rhexis margin, and then place the IOL, and then the CTR goes towards the end, and the IOL, as we said before, goes into the sulcus, and it gets, now this is the way the optic goes into the bag while the haptics are in the sulcus. Again, I empty the capsular bag by aspirating the visco inside. Otherwise, you'll get a capsular distension very much. The capsule becomes very much distended. IOL gets pushed anteriorly too much. And now this is how we capture the IOL into the capsular bag. So just for to relax towards the end, when trainees start doing with hesitation, this kind of hypermature cataract, see, then it has started, it's going towards the periphery, it is very, very gently, slowly trying to pull, it's keeping on going to the periphery, decided to retract, again cuts once again, one more cut, now it is looking like 1, 2, 3, 4. That's a new flag sign which I have found out in this kind of cases, which is that, Amit, you know this kind of flag, new flag? Yeah, this is a Scotland flag sign, so I'm going to publish this anyway. So there are different types of flag signs which can be caused or whatever. So just to show you some, because we have 5 minutes more, just to show you some, this is one pediatric cataract. Lens was placed in the sulcus and left there. So this kind of a single piece lens gets decentered badly, and that can be exchanged, but then see what happened to the rhexis margin. See the kind of fibrosis which happens and the adhesion of the anterior and the posterior capsule. I'm trying to release this, doesn't work at all. But then if you look at this area, look at this small area. There is a gap. That is what God leaves it for you. And that's a small gap area, and through that, you can see Elshing's pulse already growing out through that. So that area I can identify, and visco can go into the bag. See the bag getting opened up? The visco can go all along and open up the whole bag. But still the center is so tightly stuck that I cannot release that, and I have to go around it and cut with the scissors and go around it and try to open up the capsule, the anterior capsule beyond it. So I am opening the capsule beyond it and then completing it till till I reach the periphery, and then I become very confident, and then and the last part I just snip off and then complete it off. So that is done, but then this has to go. So I pull so so tightly I pull that I tear the posterior capsule here, see. So we have to be very gentle about all these things, and then finally I ended up getting the anterior capsule. So anyway I have to do a posterior capsulotomy. So I extend that and make a posterior capsulotomy and then place the IOL in the bag itself. So here is something which is seen in many of this shallow anterior chambers, PACGs and all those. See these anterior extended aberrant capsule, anterior capsule on zonules and anterior capsule. When you do a capsular excess, you will go into these zonules and then it will not progress as you want it to. So when you see these, please release them off with a blunt maybe a cyclotist spatula or a blunt Sinski. Don't damage the anterior capsule. It can be released off. So now you can see me trying to initiate a rexus. It goes into that and then it doesn't proceed as we want to. So please release the attachment in the anterior capsule and then proceed. So this we have seen in quite a few cases only, but this is the regular exfoliation which you see on the anterior capsule. This is not pseudo exfoliation. This is the true exfoliation. He is not a glass blower or anything, but then he is just a manual worker. But then you see this kind of the exfoliated anterior capsule. So don't take it as something else. It may be there. So it can be just ignored. You can just go through that and complete the capsulorhexis. You don't have to. This is just for demonstration sake. I am trying to bunch it up and take it up and all those. Beyond that, you can just see the whole thing is being bunched up now, and then the capsulorhexis is started separately on the capsule and finished. So just to show you that even if you think that your manual rhexis is quite good, be gentle with your anterior capsule and your rhexis margins. Otherwise, see the rhexis margin is complete here. So I'm trying to aspirate a little bit of cortex there. Rhexis margin is still intact here. See, look at this area here. But if I stretch it so much, even this can tear. So please do not stretch very badly these kind of capsules. And thank you very much for going all the way through this course, and we have finished right on time. We have 2 minutes left. We can take 1 or 2 questions if you want to.
Maybe a small comment. In a femto capsulotomy, in a small pupil, while you may not choose to do a device in the beginning, but once the femto is done, it's always wiser to use a device, because that pupil is going to come down, and that capsulorhexis or capsulotomy is not really very secure. So if you want to do any manipulations after that, what you choose to use iris hooks or an expander, it's always a good idea to use.
Absolutely, absolutely. I don't find any reason trying to do a phaco in a small pupil. There is no reason at all without seeing anything.
You're talking of a femto.
Even then, after a femto, to continue on in phaco is not at all necessary to do. Why should we do? There are expansion devices which are available, see and do. In cataract, it is almost everything you can see while you are trying to do a cataract surgery. So use devices made in India once, rings, hooks. Orolab makes iris hooks which are very small and cheap. Suven makes no financial interest for me in this. He makes BHEX rings which I am using now regularly. My usage of hooks have come down drastically. I use it only for very intumescent and small pupil cataracts where I want it to extend more than 6 millimeters. I want to see the peripheral bag also. Or in a capsular PC rent where I want to extend more on one side and see. Otherwise, almost all cases are...
Dr. Minu, I just want to ask the audience, how many of you all have your micro rexes and micro vanas in the cataract set? So still the number of people using it is very less. I please advise all of you all, go and get a 25 gauge micro rexes, micro vana set, keep in your cataract set, and you will see life changes so much when you're doing the rexes.
No, we all don't have any financial interest in that. Epsilon makes very good ones. Indo-German makes very good ones. These are the two which I know.
Bangalore Cardiocare. I used Epsilon, is very expensive, but
expensive is one side. Cheaper ones which will break off, easily is on the other side. This lasts longer. 5,000 you buy, it will break off in 3 months. So if you buy for 15,000, it will last longer.
So Cardiocare, they have a very good material. I have used different companies. Cardiocare gives you one instrument for 3,500 to 4,000 rupees. So if you take both combined together, he'll give you for 6,000-7,000 rupees. But this is very, very good. 25 gauge through a side port, and what one tip Minu was telling, the bent MVR. See, Aurolab, I don't have financial interest, but Aurolab's bent curved MVR, the diamond sharp is so long that when you try to do the side port, it'll end up in a long side port. So you should know how much the diamond length you want. The side port should not be very long, otherwise it will be difficult when you're using the bimanual or doing the rexes. So some tips here and there. Thanks a lot.